Hello and welcome to this lecture. Today we are going to discuss about sedative and hypnotic drugs, and the content of today's topic is we will discuss briefly about what is sedative and hypnotics, discuss the classification of the drugs, then we have some case studies and the problem related to that case study. So first of all, why sedative and hypnotics are important classification in the drugs? Because the drugs has been misused a lot because of that overdosage, and many of the suicides are related to these drugs using sedative and hypnotic drugs, and approximately 60% of the suicides among women and 30% among men is related to these drugs. And we know the sleeping pills, everybody is very familiar with that sleeping pills. They actually belong to sedative and hypnotic drugs, and sometimes many unplanned or acute period of ambivalence is actually because of the sedative and hypnotics. The death rate of medication overdose is around 1.5 to 4%, which is quite high, and about 85% of attempted method of suicides are via drug overdose in the developed world. So that shows as that anxiety, depression or stress related disorders are actually linked to the overdoses of sedative and hypnotics. Sometimes everybody have distress and anxiety level, and sometimes some people take intentionally these drugs, and sometimes the overdosage of these drugs can relate it to death. So this is a alarming issue, and actually these agents, as I mentioned before, is useful for reducing anxiety and calming effect, and they are responsible for actually minimum consistent with therapeutic efficacy. Especially they are talking about the central nervous system. CNS stand for central nervous system depression. And the hypnotic drugs, actually they are responsible for producing drowsiness and maintenance of the sleeps. So if some patient have insomnia or difficulty in falling asleep, so we give hypnotic drugs. And they also responsible for depressing the central nervous system. So the sedative agents or hypnotic agents both are responsible for depressing the central nervous system. So the hypnotic agents are actually produce more sedation as compared to the sedative agents. They are responsible for more we can say that more drowsiness, are producing more sleep induction as compared to the sedative agents. They are subclassified into benzodiazepine, barbiturates and some new hypnotic agents. What is actually the summary of all neurotransmitters, especially in our body? As we know that there are different neurotransmitters like acetylcholine, dopamine, and GABA is another transmitter which is known as GABA aminobutyric acid. Then we have glutamate. So they are different neurotransmitters, and their anatomical position and their receptors and their antagonists and their mechanism is different. As I'm not going to go far in complete detail of these neurotransmitters, but in general, if you see that acetylcholine actually present in all cell bodies at all cell level, either they are long or short connection. And the receptors that is usually present are muscarinic receptors, M1 receptors. So for example, we give atropine for antagonist, as an antagonist. For example, for acetylcholine, if the neurotransmitter such as acetylcholine increases, then to antagonize the effect we can give atropine. If you see dopamine is also present at all cell bodies at all level, either the short, medium or long connection, and they also contain D1 receptors, and to antagonize the effect we can give phenothiazines. Then we have GABA receptors, which is GABA aminobutyric acid, which is present at supraspinal and spinal interneurons at pre and prosynaptic inhibition. The GABA receptors are very commonly used for these receptors, and then there are drugs that I mentioned, picrotoxin as an antagonist, same like glutamic acids or glutamates. They also, so I'm not going to discuss for mechanism of action of each of the transmitters, because every neurotransmitter have their agonistic effect, and to counteract that effect we have an antagonist, and they are working by different way, either the conduction of potassium or increase of the inositol triphosphate, or working through increase of the cyclic AMP, or by decreasing of the calcium ion. So this is not required for this topic, but the main thing we want to focus on that there are different neurotransmitters present in the body at each level, and they work with different receptors, and each neurotransmitters have an antagonist to counteract these effects. So the main topic today is we are going to discuss a case study of a 22 years old woman is brought into the ER via ambulance because of the suicide attempt. Soon after a night on a town, she called her boyfriend saying that she took a handful of sleeping pills. On examination, she appeared lethargic, but groaned and moves her all extremities to painful stimuli. Her blood pressure is around 110/70 mm of Hg. Heart rate is 80 bpm. Then oxygen saturation is around 99%. Her pupils are of normal size and reactive to light. Her deep tendon reflex are normal bilaterally. In the field, she was given an intravenous bolus of dextrose and an ampule of naloxone without response. Her boyfriend, with whom she had an argument, bring the bottle of sleeping medication which read lorazepam, which is also known as famous sleeping medicine. So the summary of this is that she's woman went for emergency room, age 22, overdoses caused by lorazepam, hemodynamically stable, and no focal neurologic defects. She facing lethargic and initially given intravenous dextrose and naloxones, but the response is not there. There is no response, and then the dextrose plus glucose and water has been given, and naloxone has been given so that to reverse the respiratory depression, because lorazepam can cause respiratory depression. So the problem is, the main thing is that what happened with taking these drugs like lorazepam, such far as sleeping pill, that the danger of overdosage, and they are classified under the sedative and hypnotic medication. Lorazepam belong to benzodiazepine agent that is responsible for depressing the CNS, which is central nervous system. Then the second thing, the problem, which is that how the lorazepam act. And the lorazepam act by binding with the GABA receptors, GABA A, GABA aminobutyric acid receptors, especially with chloride channels. And what happening that with the help of GABA receptor plus chloride channel, they increase the level of chloride influx, and by increasing the chloride influx, what happening that it rendering the cell less excitable. Obviously, the responsibility of lorazepam is the central nervous system depressing agent, so they are responsible for reducing the excitability and causing CNS depression. How they act by working with the GABA receptor plus chloride and channel. So the increase of the chloride influx is responsible for the lorazepam action.
In this lecture, we're going to cover the pharmacology of anxiolytic and hypnotic drugs. So let's get right into it. The primary use of anxiolytic and hypnotic drugs is to treat anxiety and insomnia. Anxiety is generally defined as an emotional state characterized by excessive feelings of worry, fear, and nervousness, while insomnia is generally defined as the inability to initiate, maintain, or achieve restful sleep. Now, in order to gain better understanding of how anxiolytic and hypnotic drugs work, first we need to discuss the role of GABA in the central nervous system. So, gamma-aminobutyric acid, or GABA for short, is a major inhibitory neurotransmitter. What that means is that when GABA reaches and binds to a specific receptor located on a neuron, it reduces the activity level of that neuron and makes it less likely to fire its action potential. Now, GABA is recognized by both ligand-gated and G protein-linked GABA receptors. In this lecture, we are going to focus on the ligand-gated GABA receptor called GABA-A, as this is the main target of many anxiolytic and hypnotic agents. Now, the GABA-A receptor is made up of 5 subunit proteins arranged to form a central pore. These subunits have been labeled with Greek letters such as alpha, beta, gamma, and delta. The subunit composition of GABA-A receptors in the brain most frequently consists of 2 alpha subunits, 2 beta subunits, and 1 gamma or delta subunit. Furthermore, for each subunit, many other subtypes exist. The function of each GABA-A receptor depends on which subunit it contains. For example, GABA-A receptors containing alpha-1 subunit appear to be involved in sleep, while those that contain alpha-2 or alpha-3 appear to be involved in anxiety. Now, when 2 GABA molecules bind to the GABA-A receptor, conformational change is induced, which results in opening of the central pore that allows negatively charged chloride ions to rush into the cell. This in turn increases the negative charge inside the postsynaptic cell, which makes more difficult for an excitatory inputs to cause an action potential. Now, GABA-A receptors are present in high concentration in the limbic system. One part of the limbic system is the amygdala, which contains many neurons that use the neurotransmitter GABA to control feelings of fear and anxiety. In times of stress, excitatory neurons in the amygdala fire rapidly, sending excitatory signals to other areas of the brain. It is this type of firing that leads to feeling of panic or fear. The inhibitory interneurons in the amygdala regulate these emotions by releasing GABA. The release of GABA and its binding to postsynaptic receptors such as GABA-A inhibits the excitatory signals that result in feelings of anxiety and fear. GABA thus has a calming, tranquilizing effect on our emotions and prevents us from becoming overwhelmed in stressful situations. Now, in addition to a distinct binding site for the neurotransmitter GABA, the GABA-A receptor has also a site at which anxiolytic and hypnotic drugs bind. These drugs can be divided into 3 groups, that is, benzodiazepines, barbiturates, and non-benzodiazepine hypnotics. Let's now discuss these one by one in detail, starting with benzodiazepines. So, benzodiazepines get their name from their chemical structure, which includes a benzene ring fused to a diazepine ring. Their binding site appears to be the region between the alpha and gamma subunit on the GABA-A receptor. It's important to remember that benzodiazepines do not bind to the GABA recognition site located at the junction of the alpha and beta subunits. Thereby, they don't induce opening of the channel as directly as GABA. Instead, the binding of a benzodiazepine to its receptor site increases the affinity of GABA for the GABA binding site. This leads to increased frequency of the channel opening and in turn increased influx of chloride ions at the postsynaptic cell, which ultimately makes difficult for any excitatory inputs to cause an action potential. So when the excitatory signals caused by fear or stress are inhibited in this way, the result is decreased anxiety and greater feeling of calm. In addition to that, benzodiazepines can also produce mild muscle relaxation as a result of their action on GABA receptors in the spinal cord, cerebellum, and brainstem. The examples of benzodiazepines are alprazolam, chlordiazepoxide, clonazepam, diazepam, lorazepam, and temazepam. When it comes to side effects of benzodiazepines, the most common ones are related to their sedating and muscle relaxing action. They include drowsiness, dizziness, decreased alertness and concentration, as well as impairment of motor coordination. Now let's move on to the next group, that is barbiturates. So barbiturates bind to GABA-A receptor at the alpha or beta subunit, which is different from the GABA binding site and also different from the benzodiazepine binding site. Now, just like benzodiazepines, barbiturates enhance the effect of GABA at the GABA-A receptor. However, instead of increasing the ion channel opening frequency, they increase the ion channel opening duration. In other words, unlike benzodiazepines, barbiturates hold the ion channel open continuously for long periods of time. In addition to that, barbiturates can decrease the activity of excitatory neurotransmitters such as acetylcholine and glutamate, and at higher doses, they can also mimic GABA and directly activate GABA receptors, thus leading to profound central nervous system depression. This is why barbiturates have a much lower therapeutic index than benzodiazepines, meaning the toxic dose is not much higher than the therapeutic dose. The examples of barbiturates include pentobarbital, phenobarbital, and secobarbital. When it comes to side effects, barbiturates most often cause dizziness, lightheadedness, sedation, as well as memory and attention impairments. Furthermore, because of their narrow therapeutic index, it's important to remember that even small barbiturate overdose can result in coma or death due to respiratory depression. Now let's move on to our last group of drugs, that is non-benzodiazepine hypnotics. As I mentioned at the beginning of this lecture, GABA-A receptors in different areas of the central nervous system consist of various combinations of the subunits. The specific subunit that appears to mediate sedation is the alpha-1 isoform. So as their name suggests, non-benzodiazepine hypnotics are structurally different from the benzodiazepines, and as you may already guess, they selectively bind to the alpha-1 subunit of the GABA-A receptor, thus triggering chloride channel opening with resulting membrane hyperpolarization. Because alpha-1 containing GABA-A receptors are highly expressed in wake-promoting regions of the brain, the preferential binding of non-benzodiazepine hypnotics to these receptors results in sleepiness but not anti-anxiety effect. The examples of non-benzodiazepine hypnotics are zolpidim, zaleplon, and azopiclone. When it comes to side effects, non-benzodiazepine hypnotics can cause cognitive impairments, including memory loss, daytime sedation, as well as impairment of motor function. And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.
So how we treat benzodiazepine overdosage? If a patient having this problem, then the drug that has been given is flumazenil, which is a competitive antagonist at benzodiazepine receptor. So it means that this drug is also acting on GABA receptor with chloride channel and competitively antagonist and blocking the receptor action so that they decrease the chloride influx. And clinically it is used to reverse the symptoms of benzodiazepine overdosage. So the classical sign of overdoses, especially with what happened when women take lorazepam and the drinking, it leads to drowsiness, confusion, amnesia, and the overdoses of benzodiazepine rarely fatal, because the main thing is that it can depress the respiratory system. So that's happening. But obviously if too much sleeping pill has been taken by the patient because of the anxiety, depression, so it may become more combined effect of the drug that has been taken. So what happening that the benzodiazepine, especially with the use of CNS depression like ethanol, enhance the sedation and cause hypotension and respiratory depression. So usually if patient die from the sleeping pill, why? Because patient may take alcohol with benzodiazepine. Why? If we know that people that are depressed or stressed or anxiety, they take alcohol. So if someone already taken alcohol like ethanol that have a depression effect, then along with them patient takes sleeping pills like benzodiazepine like lorazepam. So what will happen that the ethanol will increase the sedative effect, and then it can cause hypotension, number one, and then respiratory depression, and then leads to coma or death. So alone benzodiazepine is not as fatal as in combination with ethanol. That's why sometimes what happened that in different parties, different drugs that has been used in different parties, like LSD is another psychoactive drug that has been used. If patient or anybody take with these psychoactive drugs plus with ethanol, then the effect of the drug will be enhanced by these agents. So as an individual drug, like in this case benzodiazepine alone is not as fatal, but in combination it is fatal. And in most of the cases, if a patient has been depressed and already taken alcohol, then along with sleeping pill, the combined effect could lead to the death. But what are the medical uses of benzodiazepine? The benzodiazepine has been used for the treatment of anxiety, insomnia, seizures. It is also used as muscle relaxant, and it is also used for short medical and surgical procedures, or detoxification from alcohol as well. And it is used in psychiatric condition as well. The chronic use of benzodiazepine for longer actions for longer time, like in weeks, can result in tolerance and withdrawal symptoms. What is tolerance? That what happened with the patient with the passage of time, the patient, because they are taking these drugs because of the anxiety or depression or stress, the effect produced by these benzodiazepine decrease with time, with the same dose, with same amount of dose that has been taken, and that is technically known as tolerance. So what will happen with the passage of time? That patient increase the dose without consulting with the doctor and increase by themselves. That is known as drug misuse. And with the drug misuse, what happened? That with the increase of the dosage, to produce the effect, same effect that has been getting from previously, is known as tolerance. So what happened? That patient slightly increase the dose, maybe one tablet, she or he take more than one, then with 1 or 2, 3 more weeks, patient feel that he need more drug to reduce the anxiety or psychiatric issues, sometimes mental factors, mental issues. And in these reasons, that patient self medication promote, and then patient will take more medicine without consulting with a doctor. And what happened? That tolerance will develop. And then if what happened, that patient take the drugs by themselves, not consulting with a doctor, and increase the dose, and then suddenly after few days he or she leave that drug, what happened? The effect will be produced, known as withdrawal symptoms. And that withdrawal symptoms would be quite severe as compared to the normal medicine that has been taken. So the use of the benzodiazepine is very critical, because if some patient take by themselves without consulting with the doctor, number one, it could lead to the tolerance. And then if a patient suddenly leave that drug, it could lead to withdrawal symptoms. And usually benzodiazepine is used for treatment of anxiety and insomnia, but they have less frequent use for tachycardia or hypertension or hallucination or seizure effects, but usually it is used for treating the anxiety and insomnia. The other new hypnotic drugs, we have zolpidim or zelpilone or zocipilone, and they are structurally different from benzodiazepine, but the mechanism of action is similar. They are also used for the treatment of insomnia, but for the short term. And the better thing is that they are having less physical dependence and less drug abuse as compared to the lorazepam. So the new hypnotic agents, they are made in such a way so that we will decrease the dependence or from that, like addiction from the drugs that can cause from the lorazepam. So the half-life will be of these drugs will be faster, and but less physical dependence, and it is used for short-term management of insomnia. Pharmacokinetics, benzodiazepine are well absorbed from the GIT. The clearance is actually through decrease in elderly patient or with patient that having liver diseases. So we need to be very careful, especially for old patient or if someone have liver diseases, because then in these cases the clearance will be decreased, and if the clearance will be decreased, then the drug will retain more in the body, and if the drug retain more in the body, then it may produce the prolonged action. So in these cases, if patient that having old age or having liver disorders, we need to give less dose as compared to the regular dose given to the normal patient. and these drugs must be avoided in pregnancy because it can cause withdrawal symptoms in neonates. When we see the pharmacokinetics of benzodiazepine and hypnotic agents, the drug that has been highlighted and mentioned, the new hypnotic agents, they are actually nowadays preferred because of their faster action, and if you see, the half-life is less as compared to the other drugs. As we mentioned before, that these in the last point, that they are less physical dependence and they are faster half-life, and maximum effect will be faster. So if you see the highlighted drugs, they are having half-life less, and their effect is faster as compared to the other drugs that having given. So that's why now the new hypnotic agents are preferred. When we discuss about the mechanism of action, we already discussed that how it worked through GABA receptor and chloride ion channel. So this is the GABA receptors, and GABA receptors have different subunits, alpha, beta, gamma, and you see that when the drug binding with the GABA receptors or GABA A receptors, what happened, that it increased the chloride influx into the cell, and the increase of the chloride influx into the cell, it leading to the decrease of the excitability, and decrease of the excitability is responsible for the effect. So that's how this mechanism works. So I'm not going to go for much detail because again we have limited knowledge in biochemistry. So just you need to understand that it works through GABA and chloride ion channel together, and binding with the GABA A receptor increase the chloride influx intracellular, and then as a result it decrease the excitability. So that's all for today's lecture. Hope to see you again. Thank you so much.